Right, well, good morning, everyone. It's a pleasure to have you all join us for today's Insight Advisory Solutions webinar on future-proofing private healthcare, understanding the shifts shaping employee cover in South Africa. I'm Anthea Towards, the Head of Healthcare at Insight Advisory Solutions, and I will be your facilitator for this morning's session. We're delighted to have so many of you joining us. I think we're up to 43 participants. This session promises to be a really insightful discussion on one of the most pressing challenges facing you as employers today, and that is the rising cost and the changing nature of private healthcare coverage in South Africa. As many of you know, affordability pressures, growing risk exposure, and access constraints are reshaping how employers approach healthcare benefits. Medical schemes are under strain, while health insurance is gaining a lot of traction and a lot of ground, and the line between these two funding solutions is becoming increasingly blurred. Today's session will unpack the trends behind these shifts. We'll also explore how they are emerging and consider what the implications might be for you and your organizations going into 2026 and beyond. Our presenter today is my colleague and friend, Christoff Raath, the CEO of Actuarial Solutions and one of South Africa's leading healthcare actuaries. We also are very pleased that Barry Childs, our Group CEO, has also joined us for this session. So welcome to both of you. Christoff needs very little introduction in many circles, but for those of you who don't know who Christoff is, he spent the last maybe two and a bit decades, advising medical schemes, policymakers, and employer groups on sustainable healthcare strategies that look at balancing affordability, equity, and innovation. And he's going to walk us through the latest data, the market trends, and also share some interesting perspectives on what employers should be paying attention to as we look towards 2026. So before we get started, just a few housekeeping notes. The session will run until 10:30. Christoff's presentation will take about an hour, and then we'll have a Q&A session. Your microphones have been automatically muted just to minimize background noise. And we encourage you to please post comments and questions in the Q&A and also in the chat. We'll address as many of these as we can at the end of the presentation. Lastly, the session is being recorded, and we will share a copy of the slides with all the registered participants afterwards. So thanks again for making the time to join us this morning. I encourage you now to sit back, pick up your coffee cup or your tea, and let's enjoy the session. Over to you, Christoff.
Thanks, Anthea. Hello, everyone. Maybe, Anthea, if you can just confirm that the visuals and the audio are coming through, and then we can kick off. So yes, thanks for the introduction and the little private joke. So Anthea said that I've spent a little more than 2 decades in private healthcare, which is a startling thought for me to apprehend. When we talked about it yesterday, I realized that the number is now 25 years, and I'm not sure if that's a good or a bad thing. She was kind enough to make me sound younger than I look by referring to this as a little more than 2 decades. So we are going to discuss the future of healthcare. This is a really tenuous and interesting time in South Africa to be discussing this. And hopefully I can help employers make a little bit of sense of what's going on. Just to give you a sense of what I hope to cover in the hour or so that we have, I'm going to talk about the medical scheme landscape and also all of the contribution increases that you would notice. Schemes are launching left, right, and center at the moment, which is why we're having this discussion. I'm also going to discuss the regulatory environment. Now, that sounds a bit boring, but you'll see that it is anything but. And then we must talk about health insurance. Normally, we think about medical schemes, but for reasons that I'll explain, health insurance is becoming an increasingly important part of our lives. And yes, we have to talk about NHI a little bit, in what that means and what the future might hold. And I hope I leave you less confused than you are at the moment. You'll probably still be a little bit confused, but I hope less confused. Just by way, again, of just housekeeping, I think we're doing this in a Teams webinar. Teams only kind of recently added this functionality. You might have seen this before. Webinars used to be a lot more common in Zoom, but I just mentioned this because if you look at the top of your Teams window, you'll see there's a chat button and there's also a Q&A button. And if you press the Q&A button, there you can click on, I think it says create post or start a discussion. And then you can either start a discussion or you can ask a question. I'll keep an eye on these as I go through, but if you have a question to ask, or if you just have something very nice to say about me or about Anthea, you can put it there. And, if we can answer some of the questions during my presentation, we can do that. At the end of the talk, we'll go to all of the posts that we have there. So you can post in the chat. We might see that, but if you have a burning question, please post it under the Q&A. If you press the Q&A button at the top, and we'll try to get to you. We can also, if you prefer, at the end of the talk, if you prefer to ask your question verbally, we can open access to you to unmute, and you can just let us know in the Q&A that you would like that. And if you're not having a bad hair day, then we could even allow you to show your camera if you prefer to ask the question that way. Okay, so without further ado, let's get going. I think if you open the newspapers on a daily basis now, you'll see news about medical schemes launching. This is hunting season, as it's known in medical scheme land, where medical schemes are spending an inordinate amount of energy and effort to launch their upcoming product changes and contribution increases, and what the benefit changes that they intend to launch and plan for next year. So far, of the 10 or so relevant open medical schemes we have in the country, 9 is launched. I show here the contribution increases. These are average contribution increases announced by, I show them in alphabetical order: Vestnet, Bonitas, CompCare, Discovery, FedHealth, MediHelp, MedShield, Momentum. I show in the light blue bar the contribution increase that was just announced. But I also show the increases that were announced last year, if you look very carefully at that shaded gray pattern, to show you that contribution increases right now are still much higher than what CPI is. And I'll explain why healthcare inflation seems to be higher than CPI is. I'm sure any HR or finance representatives in this webinar are familiar with the frustration of having to deal with these contribution increases that are almost always higher than salary increases. So we're going to talk a bit about that. But you will notice that virtually all schemes had much higher increases last year than they have this year. Just by way of, just to complete the picture, I must make 2 caveats here. The first is that Discovery's increase was delayed. They announced an increase of 7.2 on average, but it will only be implemented on 1 April 2026. And then Sizwe Hosmed has not yet launched. I think you may also be familiar with the fact that Sizwe Hosmed is recently placed under curatorship. There appear to be some governance issues there, and the Board of Trustees was removed. The curator was installed. Just very recently, a few days ago, the board that was removed challenged the curatorship in court. The court upheld the curatorship, so Sizwe remains under curatorship at the moment. And maybe because of all of that, we haven't seen an announcement from them as yet as to what the increase would be. So let's move on to why, especially last year, why were these increases? If you look at the shaded figures there, some of them, most of them were double digits last year. In fact, every medical scheme, with the exception of Discovery, MedShield, and Momentum, had double-digit increases last year. And the reason for that is that schemes built up large reserves during COVID. And those reserves that schemes built up during COVID, schemes wanted to give the reserves back to members. So remember, during COVID, claims actually went down. Of course, schemes had to pay for COVID and for PCR tests and for all kinds of things related to COVID, but almost all other medical scheme claims went significantly down during COVID. So the schemes just started building up enormous reserves. I can show it here. During COVID, you can see, if we just look at this blue line representing all schemes, see, 2020, the surpluses made by schemes were significant. Never in my career, in this very long career that Anthea just reminded me of, have I seen such surpluses being made by schemes. So it turns out that schemes wanted to give the reserves back to members. Remember, a scheme is a not-for-profit entity. It's basically like a trust. All of the money in a medical scheme belong to the members. And the only thing trustees can do with that money is to give it back to members. You can pay some suppliers in terms of your non-healthcare expenditure, and that tends to be sort of between 8 and 10% of what a medical scheme pays, but everything else goes towards paying claims, sometimes more than 90% going towards paying claims. And to give the reserves back to members, the legislation of medical schemes is very restrictive of how schemes can do that. The only way they could really do that was by going with lower contribution increases and effectively underpricing medical schemes. And that happened in 2021 and 2022, when we saw record low average contribution increases. Some of you might recall that schemes increased by 2 or 3 or 4 or 5%, which was lower than CPI at the time. For those 3 years, 2021, 2022, maybe also 2023, in an effort to give reserves back to members, the medical schemes went with low increases. Now, giving reserves back to members turned out to be harder than you think. We jokingly refer to it as reserve shedding, that schemes were trying to get rid of reserves. And I want to show why. I have a little picture. Hopefully this is not too patronizing, but I want you all to imagine an aeroplane. And imagine this aeroplane is a medical scheme, and the altitude of the aeroplane is the solvency of this medical scheme, or the reserves, the reserves that this medical scheme has on its balance sheet that it can draw from in times of need. Now, the legislation, Regulation 29, says that we must have a minimum of 25%, as most of you would know. But at the end of COVID, many medical schemes sat around 50%. Now, imagine you're a medical scheme sitting at 50% solvency. And for the sake of this picture, let's just imagine for the moment that medical inflation is 8%. I'm just using this as a number. Don't make too much out of it. I'm just picking a number to draw a picture of an aeroplane and make a point. So if medical inflation is 8%, I want to suggest that an 8% contribution increase every year would allow this aeroplane to fly level. And if you keep on increasing in line with inflation, your contribution income as a scheme will increase at the same pace as your claims expenditure. Now, let's imagine these conversations quite often happen is that a medical scheme says, no, but I want to give reserves back to members. So let's go with a lower contribution increase. And 4% is an example of about half of what my 8% would be. And of course, the intention is to pitch the aeroplane downwards so that you start paying more claims than the contributions that come in, so that the reserves can flow back to the members by virtue of higher claims payments. Now, here's the twist, is that most people think what would happen is I'm just going to have an 8% increase after that. I've now given reserves back to members and we can start flying level again. Unfortunately, doesn't really work like that. If this medical scheme went back to an 8% increase, then this is the picture that would emerge. Because 8%, as I said, is necessary to fly in a straight line. And this is what happened last year when I said most medical schemes, as I showed you, most medical schemes last year had fairly high double-digit increases. Last year was the year where medical schemes actually had to figure out how to pull out of this loss-making trajectory. So the losses that schemes were making was deliberate. If your medical scheme is loss-making, in most cases, I want to encourage you, this is a deliberate action to give reserves back to members. But at some stage, of course, you must stop making losses. So in my little picture, if this scheme went with another 4% increase, it would actually, I'm exaggerating here, but it would actually just increase the nosedive. What you do need is like a double digit at some stage to start flying level again. So what started with a gratuitous gesture of trying to give reserves back to members ended up at the end of last year coming back to the point where schemes had to pull out of those losses. Most medical schemes had to do it. It was painful. And you might recall that most medical schemes had high increases last year. But to a large degree, the industry has now done that and has started flying level again. So as I said, reserve shedding turns out to be a surprisingly hard thing to do. But it comes from a position post-COVID of trying to help consumers, albeit temporarily so, by keeping contributions lower than they would have been otherwise. Still, you're still going to say to me, like, look, most of the medical schemes that they've just launched have increases of, like, I think the lowest one is below 7, around 6.8 and 7.2. And then we'd see 7.5 and 8% and 9.9%. I haven't seen a double digit so far this year in the open scheme market. But, why is it so high if inflation is sitting around 3 or 4%? And this is why. I'm going to talk at length, really today, about why the regulatory environment in which we found ourselves make it hard for medical schemes to keep contribution increases in line with inflation. There are many reasons why contribution increases are higher than CPI. Some of them are good reasons. Most of them are not such good reasons, but not reasons that schemes have a degree of power over. And I want to suggest that inflation can be broken down for a medical scheme. If you look at a contribution increase, it is actually made up of all of these components that you see here. Tariff would be to say, well, a GP consultation is going to cost 500 Rand next year, whereas it costed 450 Rand this year, whatever the numbers are. So just whatever you pay. And if you look at a tariff increase, you would assume, and we often, when I talk to doctors, I hear this criticism. Doctors say, but I increased my tariffs with only 4%, and the medical schemes increased their contributions with 9%. Like, who's taking that 5%? Who's pocketing it? The reality is that that other 5% is what we often refer to as utilization effects, because they're not related to price, and that can be broken down into demographics, into option downgrades, and into supply side effects. Demographics is just to say that medical schemes are getting older over time. Of course, we don't have a compulsory environment, and that's a big part of today's discussion is what compulsory means. It means that if young and healthy people decide to leave the medical scheme world, then they leave behind an older, sicker risk pool, and the medical scheme must increase contributions to fund the, on average, less healthy pool. Unfortunately, this is a regulatory deficit that we have, but this happens literally every year. And in the open schemes, I think you can say roughly 2% of every contributions increase every year is because people are getting older over time. So that's the first 2% over, let's say the GP increased their consultation price with 4. There's about 2% over and above that because of young and healthy people opting out. There's another 2% that I would attribute in multi-option schemes like open schemes to people downgrading over time. So a medical scheme might have a range of options and you say, hang on, I'm going to go to the low-cost option. But as progressively older, sicker people start buying down into those low options, those lower options must also increase their contributions, unfortunately. Roughly speaking, that's about 2% of what we see on average. And then there are supply side effects. So some of this is good, some of it is not so good. But in the main, what we're looking on the supply side, as we call, it's something like new technologies coming out, which is great, like new treatments that are spectacular. Every year, we see fantastic new technologies hitting the market. Literally something that can cure cancer that couldn't be cured before. But from a financial perspective, that means that a medical scheme is going to pay for something next year that it didn't pay for last year. I hope that makes sense. That's actually a source of inflation. And unfortunately, a lot of the new technologies hitting the market are incredibly expensive. We see cures, biological treatments for rare conditions that can run into hundreds of thousands of rands for one patient just to get that treatment every month, like into over millions in a year. And so, from some part of this 2% at the top is great in the sense that new technologies are hitting the market, but it also means that there's a cost pressure. So roughly speaking, I use very crude terms, but I want to say that the medical scheme sees its expenses, it claims, increasing about 10% in a year if the tariff increases are only 4%. And most of this, the 2 plus 2 plus 2, or the 6%, could have been significantly less if our regulatory environment for medical schemes was better designed. And that's what I'm going to talk to next. So like I said, a regulation is normally a boring subject, but hopefully I can find a way to spice it up a little bit. So to say, there's a big difference between 4% and 10% as an increase. And a large part of that is because I want to suggest that we live in an incomplete regulatory environment. The way I want to show this is if we go back to ANC white papers and discussion documents and policy going back all the way to 1994, what the plan was before 2007, before NHI emerged as our national imperative. The ANC and the white papers of the ruling party at the time said that we want a couple of things to happen to medical schemes. Those were introduced in 2000. The first is prescribed minimum benefits. That's to say every medical scheme must pay for certain things that are stipulated in the law, which is actually quite comprehensive. And you'll find that if you go to a hospital for any kind of emergency or anything really serious, you'll find that it's covered in full or almost in full by a medical scheme. The benefits that typically run out are not those. The benefits that typically run out would be something like dentistry or optometry. But if a couple gives birth to a premature baby that costs 4 million rands to treat in the neonatal ICU, medical schemes typically pay those in full because those are mandated benefits that must be paid by law. We were also quick to introduce something called open enrollment. That's to say, if you apply to an open medical scheme, they must accept your application. They can perhaps impose limited waiting periods, like say, we're not going to pay claims for 3 months, but in the main, they must say yes. This is, of course, not true for other forms of insurance. If you approach Sanlam or Old Mutual and say you want life insurance, they can actually decline the quote. They can say, sorry, we're not interested in covering you. A medical scheme cannot do that. A medical scheme must say, yes, we will cover you. That's called open enrollment. And then finally, we have something called community rating. Again, if you went to Sanlam and Old Mutual and you want life insurance, and they say, okay, we're going to do some health checks and test your blood pressure and cholesterol or test you for HIV. And if it looks like those tests suggest that you're high risk, then we're going to charge you more for your life insurance. Medical schemes don't work like this. Medical schemes, everyone pay the same price, regardless of the state of health. Now, these are great, right? It's great to have open enrollment. It's great to have community rating, but you must consider, of course, as I said earlier, that our risk pools are not protected, and young and healthy people can opt out every year. And I've already suggested that just that, the fact that people can move between options, the fact that young and healthy people can drop out of the environment whenever they choose to, means that we have an inflationary impact that's driving costs up by more than we would have wanted to see. So these are great, but there were some measures that we were going to implement. And these were part of our plan. They were draft amendment bills that were already circulating in 2005, 2006. Without going into too much detail as to how they work, we wanted in South Africa to have risk-based capital, which is a different way of holding reserves. We wanted risk equalization to suggest that if one medical scheme grows too old on average, other medical schemes would support that medical scheme. And very important, we wanted mandatory cover in South Africa, which was to say that if you are young and healthy and you can afford to belong to a medical scheme, then you must have a medical scheme. Mandatory cover is really what Obama did in the United States under what was called Obamacare or the Affordable Care Act. He said, look, if you can afford health cover, you must buy health cover. And that sounds draconian, but it is in order, to keep the young and healthy in the system so that they can cross-subsidize others. You need something like that. You'll see a blog post on our website. You'll find it at this QR code or that URL, which shows that over the past 25 years or so, open medical schemes increased their contributions by 32% more than closed schemes. And the reason for that is that closed schemes, which I show here in the light blue, closed schemes are more protected against anti-selection or healthy people opting out, whereas open medical schemes are less protected instead. So if you can belong to a restricted scheme, normally you'll see that the contribution increases of that restricted scheme is lower than open schemes over time. And there are two reasons for that. There's plenty of reasons, but two important ones are, first, these restricted schemes often only have one or two options, so the effect of option downgrades is less. And second, there's often, and now I'm speaking to all of the HR people in the room, there's often a condition of employment. And this condition of employment is a blessing and a curse, right? So people hate it to be told where to go, but to protect the risk pool from which everyone benefits, you must have the healthy people remain, rather than opting out if you don't need the cover, then coming back if you do need the cover and submit a claim, and then opting out again. That's a pressure that all open medical schemes have to look at. So we must talk about a condition of employment, right? You have young people and you have older people. We know that claims increase significantly as you grow older. Of course, young and healthy people tend to believe they are invincible. If you're young and healthy, you don't see yourself being diagnosed with a dreaded disease, maybe acquiring cancer. You can get it, but you often don't think you will. Young people tend to be incredibly optimistic, which is great. I was probably also very optimistic 25 years ago, as Anthea just reminded me. But you need young and healthy people in the system in order to cross-subsidize the others. And this is why we have conditions of employment. If you have a restricted medical scheme, it's also why an open medical scheme is probably going to suggest to you that you should try to have a condition of employment if you want underwriting-free cover. It's to protect the risk pool, to make sure that the young people and the older people are all there, so that the overall cost of belonging to a scheme can be lower. Now, if we could today bring all of the young and healthy people in South Africa back into medical schemes, all of the ones who can afford, who have jobs, who earn enough to pay for medical schemes, if we could wave a magic wand and bring all of them back into medical schemes tomorrow, I'm going to sound like a previous president now and say, listen carefully, but we could reduce medical scheme premiums probably around 30 to 35% overnight if you could bring those people back into the open scheme environment. That's even not an insignificant thing to say. That's why I've asked you to listen carefully. If a family pays 15,000 rands a month for medical scheme cover at the moment, it means that could reduce to 10,000 rands a month. It's not small change. And this is why medical schemes are so protective of conditions of employment, and why restricted medical schemes, this is a classic fight that I've seen so many times in the excos of listed companies with restricted schemes, with kind of the CFO on the one side of the table looking at the cost of the medical scheme, and HR on the other side of the table, just absolutely furious. Sorry, I have an alarm here that I need to turn off. HR absolutely furious that, why do we have this condition of employment? And this is the fight. This is the conflict that we apprehend everywhere we go. I want to show you the same problem in a different way. And let's imagine one medical scheme. Let's imagine two schemes. I'm going to call them Scheme A and Scheme B. And we could do the same if we talk about two options, benefit option A and benefit option B. Imagine they provide similar benefits, but the one medical scheme is younger and the other medical scheme is older. And so as a result, I'm just picking arbitrary numbers here, but the cost, the premium or the contribution of this older scheme is more for the same benefits. Right now, imagine your employees happen to be on Scheme B. Of course, your response, and Anthea will say to me that she sees this on a daily basis. Of course, you say, well, we would like to have a basket of medical schemes. We would like split risk. If this was a restricted scheme, which is older and pricier, the same happens. We want freedom of choice. We would like to have the option of going to an open medical scheme with all of these options that we can belong to. Now, why would schemes typically resist this? And of course, the reason is exactly the same phenomena that I just described nationally is playing out within a medical scheme as well, is that the young and healthy members would be the first to leave. Young and healthy members change the schemes quite easily. It's not a big decision. If you're 28 years old and healthy and you don't have any chronic conditions, you terminate your membership at one scheme and just move to another one. It's really nothing. But if you are 55 years old or 75 years old and you have a lot of chronic conditions, it is a pretty big decision to change healthcare cover. You don't know whether your chronic conditions will be covered on the other side. You don't know what the formula is going to be. You don't know if the networks are going to work for you. So, it's a difficult decision. And so quite often the young and healthy members end up being much more mobile. And of course, what will happen now? You already know what my next slide is going to look like. This older scheme becomes even older. And that's why you will find that people need to protect risk pools. That's why you'll find these things are exactly the same. But first, employers with restricted medical schemes will normally want to impose a condition of employment. So you must belong to this medical scheme. Perhaps unless your spouse belongs to another one, but you must belong to this medical scheme because you want to protect the risk pool. Exactly the same phenomenon. Open medical schemes tend to resist split risk. And split risk means if you have all of your employees at one particular medical scheme, of course, and you go and say to that scheme, we would like to have a basket of schemes, you will find that this is resisted, that schemes do not respond very well to that and probably want to come back and impose underwriting conditions, etc. And actually, these are difficult discussions, but I just want to say, the response from those open medical schemes is completely understandable because if young and healthy people leave, things will become even worse. Nationally, as I said, we would advocate for mandatory cover for everyone to belong to a medical scheme. And risk equalization would then be a way to make sure that if one scheme becomes very old or one scheme becomes very young, that there would be fairness in the way that they compete against one another. We don't have any of these things, and progressively conditions of employment are being cancelled, and progressively we find that split risk is becoming more of a thing. I know every principal officer of every open scheme that I talk to deal with split risk applications on a regular basis. It's extremely difficult for them to deal with this. Now, this does paint a bit of a hopeless picture because let's go back. The root cause of this problem that we're looking at here is that the regulatory environment was designed with open enrollment and community rating, but we never got the risk equalization and mandatory cover that would have created a stable medical scheme environment. So medical schemes must solve for the mandatory cover by encouraging people to impose conditions of employment, which is a little bit like mandatory cover. If you don't do that, your risk pool will recede and deteriorate. And this is why we live in a consolidating environment. Consolidation of medical schemes is continuing. If you followed all of the launches of schemes announced very recently, you would have seen MedShield said at their launch that they are thinking about amalgamating with FedHealth, and FedHealth confirmed that at their launch, which was just 7 days ago, that it's thinking of amalgamating with MedShield. We only have really like 10 large open schemes left in the country, and that number is reducing. Why? Because the larger a risk pool is, the less you are at risk of anti-selective opting in and out, etc. So in the current regulatory environment, we'll probably see that continuing. So I guess I just wanted to give you the sense of risk pools and aging and anti-selective joining and leaving and how that drives inflation. And I know I have full sympathy with the frustration when salary increases are sitting at 3 or 4% or whatever they might be at the moment, and a medical scheme comes and say, excellent news, we've only increased our contributions by, 7.5% or 8% this year. And you're like, that's so much higher than the salary increases. The reasons for that is mainly attributable to deficits and flaws in the regulatory environment that we have. And I'm going to talk about NHR a little bit in a second, but the point is just that that because of the regulatory focus on NHR, we don't see medical scheme land being repaired at the moment. Hopefully that will change. Okay, so now I must just for 10 minutes pivot to low-cost solutions and health insurance. And I want to start by saying that we like to say that 15% of the country belongs to medical schemes and that the private sector only covers 15% of our country. It's true that 15% of our population belong to medical schemes, about 9.9 million people. It is not true that 15% of our country make use of the private sector. And if I could ask, I'm not going to because we're on a virtual call, but if I could ask everyone in this meeting, do you know of someone who doesn't belong to a medical scheme, who have spent money in the private sector in the past? Of course, you will know someone like that. The classic example that I often use is an Uber driver or a taxi driver, perhaps doesn't have medical scheme cover. If you need to see a GP urgently or a dentist urgently, you're not going to stand in a queue at a public clinic. You're going to go straight to the dentist, pay cash out of pocket, and move on, or to the GP. And so we don't know how many people there are that do this, but we have got some surveys from Stats SA that suggest we're probably talking about 30%. So let's show the picture like this. If we have 15% of South Africans covered by medical schemes, it means that we have 85% uncovered by medical schemes. Now, roughly speaking, the national health budget for the uncovered is around 271 billion. The most recent budget, it's a little bit more. And roughly speaking, what medical schemes spend is also about 250 billion, roughly the same amount of money, but going after only 15% of the population, which is the medical scheme premiums that medical scheme members pay out of their own pockets, and another almost similar amount coming out of the national budget for uncovered lives. This is the classic picture, and I'm going to show it again in a few minutes, but this is the classic picture that you'll see whenever we talk about NHIs, that this is unequal. We're spending so much more in the private sector than the public sector, but the picture is not complete. There's some amount of money that's being spent outside of medical schemes, out of pocket. When you go to a GP, so look, I don't have a medical scheme, but I'm going to pay you cash. And we don't know what the amount of money is, but we do know that there's about 30% people sitting there. So I can also draw the picture like this to say, while we have about 9 million people in medical schemes, I would think we have about 12 million people based on the data we can see in South Africa that actually regularly make use of the private sector. And it's interesting, we've tried and failed for probably half of the 25 years that Anthea mentioned to put a solution in place for these people here that make use of private medical scheme, of private providers, but don't have medical scheme cover. And interesting enough, these people that I'm talking about are not interested in the prescribed minimum benefits that medical schemes must provide. Surveys throughout the past 20 years have shown time and time again that these are lives who say, we can't afford PMBs, we can't afford. So today, PMBs probably cost well in excess of 1,000 rands per month. On average, probably in the region of about 1,500 rands. This was a report by Council in 2020 suggesting 1,000 rands, but today I estimate this number to be about 1,500 rands. It's like the cheapest cover a medical scheme can provide today is on average 1,500 rands per life per month. For a family of 3, that means 4,000 to 5,000 rands. Of course, not every South African can afford that. And interesting enough, surveys have shown that they're also not interested in hospital cover. That the stuff that that low-income South Africans really want, and maybe some of you on the call can associate with this, is private primary care, GPs, optometry, and dentistry. When the LIMS study was done, it was chaired by Jonathan Broomberg back in 2004, 2005, and 2006, and the survey suggested that low-income South Africans said they're more interested in primary care cover than hospital cover. It was a surprising finding. And when people were asked why, they said, look, I'm happy to go to a public hospital, and this is still the sentiment today. I'm still happy to go to a public hospital if disaster strikes, but what I cannot do is sit in the queue with a crying baby for 8 hours waiting to get to the front, often to be chased away by a rude nurse, if we're being honest, and maybe a packet of pain pills. And this is the reason I would like to have cover for private primary healthcare. So there's a dire need in South Africa for some form of cover that's not PMB cover. Unfortunately, our regulatory authorities are extremely, are very much against this, very resistant to enabling something in the space because it's deemed to be contrary to the NHI agenda. So these are lives who presently go without cover unless they go for insurance cover. And that's what I want to chat about next. So insurance, why do we have medical schemes and insurance companies? It is unnecessary, it is confusing, but it goes back all the way to 2006 when Guard Risk at that time went to the Supreme Court of Appeal on gap cover. And there was a ruling by the Supreme Court of Appeal saying that insurers are allowed to provide gap cover, which of course covers the gap that a medical scheme might not pay if you do go to a hospital. That was the genesis really of what's today called the demarcation process, or often called the demarcation debate. After many years of digesting and dealing with the contents and the consequences of this judgment, we now have these kind of 4 products: accident cover, gap cover, dread disease cover, hospital cash plans, which I'm not going to talk about, but those are insurance products, not medical scheme products that are available. But there is now a 5th one, and those would be called exempted primary health insurance cover. So in 2017, a limited list of insurers got a temporary exemption from the Council of Medical Schemes to say you can provide cover for private primary health care, like GPs, dentistry, etc. Like I just mentioned, we will, on a temporary basis, allow you to do that while we enable a regulatory framework for medical schemes to offer this cover that doesn't include all of the PMBs. Now, the medical schemes has to date not been allowed to offer cover that doesn't include PMBs. Sometimes these are referred to as low-cost benefit options, or LCBOs, just another unnecessary acronym, but essentially just saying that you want to provide cover for medical schemes that's private primary healthcare, maybe out of hospital more than the PMBs that are predominantly in hospital. So we have a list of insurers. This is not the complete list. There's been a fair amount of movement and that these limited number of licenses that have been allowed to trade in the space. Doesn't matter who they are, just that there are a limited number of them, and no more exemptions are presently being granted. So there are, Old Mutual bought Generic, which had one of these exemptions, and there's some of these licenses are being used by other companies. I think everyone knows that Discovery is presently partnering with Auto in General as an example, and there are many other examples of how people are providing insurance through these exempted licenses. This was granted in 2017, right? It was supposed to last about 2 years while medical schemes get their low-cost benefit option framework ready. That never happened, and almost every year or every second year, we saw the council just extending the exemption for this limited number of insurance yet 1 year. More recently, on 30 March 2025, or you can see here, it was going to expire on 31 March, and it was an open secret that it was going to be extended yet again. Presently, it's going to expire on 31 March 2027. So another 2 years, and we're not sure what's going to happen then. So we have these products in the market. They're extremely popular from what we can tell. They're not regulated like medical schemes are. They're much more free to maneuver and to offer some innovative and interesting benefit designs and pricing structures that medical schemes can't. We don't know how many people are covered by them. Why? Because they're not regulated and we can't see the full detail. Recently, we saw the council, after there was some litigation on this, releasing a discussion document about whether medical schemes should be allowed to do this. The document was dated 2023, but it was only released recently, perhaps because there was some litigation from BHF around that. Without going into detail, this document was quick to propose that medical scheme, that the insurance products should be phased out, and then to suggest that medical schemes must provide this cover, but it says that the cover must be comprehensive and that 1,000 a month might be affordable. And with respect to the authors of the document, 1,000 rands a month is not an affordable product for healthcare cover for the majority of South Africans. Why should we bother? Why can't we just allow insurers to continue? Of course, we can allow insurers to continue to do this work. And I'm sure many of you are approached on a regular basis by offerings from insurers. There would be some benefits if you put this in the medical scheme environment. The non-health expenditure or admin would be a little bit lower. Medical schemes are not for profit, so the premiums might be lower. There are tax credits that I'm going to chat about just now, and then it would be more regulated. But unfortunately, schemes are still not allowed to play in this space, and not necessarily for good reasons. So what is happening at the moment? So we have this kind of insurance space and medical scheme space coexisting, and advertently or inadvertently starting to actually cooperate. So what we now start to see, and you might have noticed this if you look at medical scheme launches, and it's a kind of advice that you might get from your advisors, is that some medical schemes are cutting benefits because it's just getting too expensive. And I can draw it like this. So this is the medical scheme. It's community rated. Everyone pays the same premium, cutting some benefits. Maybe introduce big co-payments if you go to hospital. But then you might notice that there's a gap cover product available, not necessarily from the medical scheme or its administrator, but it would be somewhere in the market with gap cover that can plug the gaps in the medical scheme cover. This gap cover would be risk rated, which is fancy words for saying that this gap cover would cost less if you're young and healthy, and it would cost more if you're old and unhealthy. So you can see what's happening at the moment. Risk rating is slowly coming back into the private sector. It's unfortunate, it's completely understandable. As I explained earlier, medical schemes are at risk of losing young and healthy members, and the cost increases are reaching a point where it's just not sustainable anymore. So in an attempt to attract young and healthy members back, unfortunately, this is starting to happen, and we can completely understand why it happens. Medical schemes cutting benefits so that those benefits can be plugged by insurance products, and those insurance products would, of course, be risk rated so that the package is cheaper in the hands of the young and healthy individual. Of course, this comes at the unfortunate cost that the same package would be more expensive in the hands of an older individual. A similar phenomenon is happening when I talk about private primary healthcare insurance, is that we have these exempted primary health insurance products out there that offer GP, dentistry, optometry, maybe a little bit of hospitalization. So what might some medical scheme members do, and many of your employees are probably already doing this, is let's take, in our medical scheme, we just buy down or downgrade to a hospital-only plan, which will cover me only if I go to hospital, and then I purchase one of these exempted primary health insurance products, which will cover me if I need to go to the GP. So again, this means that this part here is often effectively risk rated, because these insurers can offer the products at different prices in different circumstances. So I'll draw the picture like this. I think what's happening, and it's not necessarily fortunate, but it's completely understandable. The market has to solve this problem of low-cost products, and it has to solve the problem of attracting young and healthy people, and it's doing it advertently or inadvertently by cutting benefits and replacing medical scheme benefits slowly with insurance products. And the regulation, for the same reason, is slowly transitioning away from the CMS to other medical schemes. And if this trend continues, we might see, I'm not guaranteeing this is the future, but we might see that medical schemes will slowly offer less and less cover and maybe recede to PMB only, while we see more insurance and more gap cover in the future. And I'll come back to that right now when I close. What the regulatory authorities, what the Department of Health, the Council for Medical Schemes should probably do is to fix the regulatory environment unfortunately, I think more likely we'll see, that they will probably discourage this kind of behavior and suggest that people shouldn't do it. Maybe try to withdraw the exemptions of the limited number of insurers out there. That will be met with fierce litigation and unlikely to be successful. If they wanted to solve the problem on the grassroots level, on a root cause level, it should have been through the introduction of some form of mandatory covered risk equalization, which would make medical schemes a lot more sustainable. But that's unlikely because it's just so politically unpopular today to fix the medical scheme size. Because why? Because national health insurance, which is just what I want to spend my last 5 or 6 minutes on before we wrap up. So let's talk about NHI. And apologies, we all a little tired of talking about NHI, but I guess if we talk about the future of healthcare, it's inevitable that we must talk about it. The NHI bill has now been signed, and so it is law. It's not been promulgated yet. There are lots of details in there to talk about, but if I can single out 2 main issues, money and Section 33. Like, where will the money come from? That's problem number 1. And problem number 2 is, what will medical schemes be able to do, or what will happen with private cover post NHI? And so if you look at all of the opposition against the NHI, it's really one or both of these things. I'll talk briefly about the finances, and then Section 33 of the NHI Act says that once the NHI covers something, medical schemes will not be allowed to cover that same thing. So that means if at some point in the future, the NHI says that, let's say, gynecologists are now covered by NHI, Section 33 says that on that same day, effectively, medical schemes will need to stop paying any gynecologist benefits. And so you can see why people are worried about that. And if you look at all of the litigation, Solidarity was quick out of the blocks to challenge this in court. BHF was also quick out of the blocks. The South African Private Practitioners Foundation, under Simon Strawn, which is a pediatrician, a bunch of specialists out of the blocks. HASA, the Hospital Association of South Africa, they tried to debate and to engage in discussion for quite some time, unsuccessfully, also litigating. The Health Funders Association, also an association of medical schemes, launched a comprehensive substantive challenge against NHI. The South African Medical Association also, and this is not even a complete list, I think we're sitting at 8 and maybe soon 9 legal challenges. I've never seen such a vast challenge against an act. This is going to be tied up in court for quite some time. And all of these talk about, some of them are procedural, like what's the right process form, that people listen to the public consultation, and some of them are substantive, like saying this act just can't work, with a lot of emphasis on Section 33 and where will the money come from. The DA is also not yet, they talked about maybe taking it to court. I guess it's always difficult if you sit inside of the government of national unity. You have to choose. Do you try to fix it from the inside, or do you try to fix it from the outside? I don't want to defend or attack any political party here, but just to say, I guess those are difficult decisions to make. We're still trying to figure out this lovely cartoon from Gary Larson. We have good news and we have bad news. And South Africa, I'll hear from all of you in the Q&A. But in South Africa, we're still figuring out whether we have a good new or whether we have a bad new. And I guess time will tell. Now, in this question, let's deal first with the money and then with Section 33, and then I can wrap up. But where will the money come from? There's differences of opinion between the Department of Finance and Department of Health. It's quite interesting, 26 February this year, that the Minister of Finance turned around and said the Minister of Health must tell him how much money he wants for NHI. Now, this sounds like a trivial and an obvious thing for a Minister of Finance to say, but the reason this was so profound is up until 26 February 2025, whenever the Minister of Health was asked, well, how much will NHI cost, or what will it cover? The Minister of Health kind of deviated and deflected by saying, well, don't ask me that question. It's the Minister of Finance job to decide. He will tell me what the budget is, and then we can figure out what the benefits will be that will be in that budget. Actually, if I can quote the Minister of Health, my recollection is that he said, people who ask me this question about the cost of NHI does not understand how governments work. And he kind of, you can see the political gaming, right? So I think he kind of just wanted to deflect to the Minister of Finance. He will tell me how much money it is, and then we'll work with that. And then in 26 Feb, the Minister of Finance made the statement to say to the Minister of Health, you tell me how much money you need, and then I'll put it in the budget. So this puts the ball firmly square back in the hands of the Department of Health to try and figure out what the cost would be. So what do? If you put a comprehensive package in there, the cost will be prohibitive, and the Minister of Finance will probably tell you it's not possible. If you put a thin package in there, then perhaps it would be an unimpressive and not coming close to the promise of all healthcare free at point of charge. And many of you would be familiar with something called the Laffer curve. An economist with the surname of Laffer said many years ago that there's a point where you can't increase taxes anymore. I think the Department of Finance and most economists believe South Africa is already at this point. In fact, if you look very carefully, when we increased VAT from 14 to 15%, the total revenue collected from VAT actually went down. You increase that, but the total tax collected goes down. Why? Because this has an oppressive effect on the economy. And certainly, I think Treasury does believe that we are at the point where we can't really increase taxes anymore. Or if we did, we would just collect fewer taxes, lower taxes. And this year was spectacularly visible how hard it will be to increase taxes. I mean, they started with 2% VAT and couldn't even increase it with 0.5% ultimately. And of course, I think the reality is that what we're looking at is not a reflection of healthcare. We're looking at a reflection of South Africa's lack of economic growth. This is a tragic picture. You can read a little bit more in Barry's blog post at that URL or the QR code that I have here, that in 2009, more or less, South African economic growth just stopped. That's the red line. And it doesn't matter who you look at. You can look at lower middle income countries in Africa. You can look at upper middle income countries in Africa. You can look at rich countries. You can look at poor countries. You can look at Africa. You can look at Southeast Asia. You can look at any country. The economic growth there has been consistent, but not in South Africa. And roughly speaking, we would have had an economy today that's 50% larger than it is today if we just grew with the average growth of other countries over the past 10, 15 years. 50% larger economy, roughly speaking, and I'm oversimplifying many things here, we would probably have 25% more jobs in the country today. Can you imagine what the impact of that would have been if we had 25% more formal employed jobs? And then we would also have had 25% more people covered by medical schemes, probably around 11 or 12 million people rather than the 9 million that we have. So maybe the root cause of the inequality that we're struggling with shouldn't look at medical schemes and try to fix medical schemes. We should look at the economy and try to fix the economy. Now, where will the money come from? According to the Department of Health, and this question has been posed to the DDG, Dr. Nicholas Crisp, who is in charge of NHR, and he kind of points to certain potential pots of money. He said, well, there is the existing state budget. There's all of the medical scheme contributions, of course. These are the contributions your employees pay on a monthly basis. So there has been suggestions throughout that one could tax your employees an amount equal to whatever they pay to medical schemes today, and then this money will just move across to medical schemes. There have been limited suggestions that medical scheme reserves could be targeted. I don't think that's likely, so I'm not going to spend time on that, but I do want to talk a little bit about this because this is quite relevant to all of you right now. Dr. Crisp has also said that he might look at the subsidies that GEMS, public servant employees, and the police service enjoy, and you can kind of flag those as part of the debate. But let's talk tax credits. You would know that your employees, whenever you participate in a medical scheme, this is not true for insurers, but it is true for medical schemes, you get a tax credit. Hopefully, We're in tax season today. Hopefully all of you have submitted your tax returns recently. If you're not on provisional or some other tax system, then you would have done that now. But if you look very carefully at your tax assessments, you will see that just by virtue of belonging to a medical scheme, if you belong any scheme, you get a tax rebate of this amount of money. The first two dependents, the main member and the first dependent, you get about 364 each, and for every other dependent, you get 246. A family of 4, therefore, today gets about 14,600 rands back in a year out of the taxes that you pay. Now, for very wealthy people, this might not be the end of the world, but if you think, if the total taxes you are eligible to pay is 20 or 30,000 rands, then it means you get 15,000 rands of that back. It means you pay 5 instead of 20 per year, or it means you pay 15 instead of 30,000 per year. The tax credits is a really big deal, and you can just imagine the pressure on your lowest income employees if they overnight need to pay this much tax more in the next year. Now, the good news is that if we look at what the department, what the budget speech said in February, after all of the fights around that, we can see the political kind of positioning that the Department of Finance did not change tax credits. But you would have also seen literally in the past week that there was more movement where Dr. Nicholas Christoff on various publications said that tax credits are going to stop. Of course, he said that we are going to start with higher income South Africans only. So I think they are recognizing how devastating something like 15,000 rand would be for a low income employee. And we can draw the picture like this. So, if we draw the entire South Africa from poor to wealthy here, and we say 15% of the country belong to medical schemes, including your employees, but within medical schemes, there's also a spectrum of income from high to low. And I show the low income in red. And of course, what the tax credits would do would be to make it least affordable for the lowest income of medical scheme members. And, that might create a new missing middle that's kind of going to drop into the uncovered domain. So you will see that Dr. Christoff was quite careful, fortunately, to sandbag the announcements recently to say that this will be limited to wealthier medical scheme members, and we still have to see the detail of that playing out. But I think for anyone in HR finance, very important to keep an eye out on what's going to happen in this tax credit domain, because it could be devastating in due course to potential low-income employees. And if they want the full 35 billion, and you'll see there's been many references to the fact that this is 35 billion rands. If they want the full 35 billion to be made available to medical schemes, then ultimately they will have to take all of the tax credits, which is why we're worried about it. All right, so let me wrap up. What does the future hold? So this is really unfair. I know actuaries are supposed to talk about the future, but we couldn't have asked for less uncertainty. I remember once, for more uncertainty, I remember once I watched, I think it was a Formula One Grand Prix, and the sports commentator, there was kind of a lull where there wasn't anything to say. And the sports commentator said, but anything can happen. And normally anything does happen. And I feel a little bit like that anything can happen and normally anything does happen. I showed you this is kind of the inequality that we face today, the classic perspective that 15% of our country spends half the money, which is 5 to 6 times higher than what we have in the public sector. So if I can draw the picture like this, there are two potential futures. The one that we are very worried about is what we might call transitional harm. Is that in the transition towards what NHI is intended to become in many years from now, we'll actually see medical schemes becoming smaller and more expensive. So this bar is getting thinner and it's getting higher. And that would also mean that there's more people that must make use of the public sector budget. So the irony is that in this scenario, you'll actually see inequality increasing in the transitional process towards NHI. There's been many alternative approaches suggesting maybe we could bring in risk equalization, mandatory recover, and a bunch of other things. Maybe the private sector could do it on its own without the regulation, without the impetus of a government doing so. And the analysis exists. HARSA, Dr. Richard Friedland from the Hospital Association presented an excellent analysis just a year ago now on what that could look like and how it could improve equality. It's not clear which of these scenarios we go for. Maybe one way to think about scenario planning, I always like to think, there's like two axes to think about. The one is that the policies could change, the act could change, or the act could not change, like maybe Section 33. Will it happen? Will it not? Will it be implemented? And then the other axis to think about is that, there might be a strong implementation, there might be a weak implementation. Just to say how severely and how strong will these implementations come through. If I had to, if this was a betting game, with all of the uncertainties I note, I think we're probably going to end up somewhere in the top right of this chart. Many people would disagree with me there. So take it where it comes from, where probably there will be a bit of policy change. I think after all of the litigation, we are going to see a softening of the stance on whether medical schemes may still pay for your gynecologist in my earlier example after NHI, and maybe a weak implementation. And we see the sandbagging. This picture that I show here is often presented by the WHO and by the Department of Health, saying, but NHI will start small. This little blue block within the bigger block will start small. It won't cover everyone. It won't cover all costs. It won't cover all services, and then it will increase over time. If this doesn't happen, I'll end up with a dramatic picture, of a phoenix rising from the ashes. I hope this isn't our future, but I think, we would always be better off if we have the social solidarity, mandated minimum, community-rated medical scheme environment that we have, if conditions of employment and ultimately a national mandated participation for young and healthy people could be maintained. That would be first prize. If that doesn't happen, and if medical schemes are kind of phased out, and if the territory that they cover reduce, the insurance industry will take their place. I think it was Dr. Debbie Piermain from the Board of Health Funders who recently said that if medical schemes were ever destroyed, the insurance industry would be the phoenix that would rise from the ashes. Isn't that a dramatic note to end a talk on at 10 o'clock on a Wednesday morning? So I'll just summarize. I think there's a lot that I've tried to cover in a short space of time. But let's say, we have regulatory challenges. Medical schemes have community rating open enrollment without the features that are required to make it sustainable, and that's why medical scheme inflation is high. There's confusion, like what is insurance, what's medical schemes, why do we have both, why do they differ? But regardless of all of this, the market is solving for ways to provide low-cost products, and exempted primary healthcare insurance today do that. And then we also see this like hybridisation, these pictures that I showed that progressively you might find that Anthea and the team or your financial advisor might advise you that in the short term, it makes sense to take out a combination of medical scheme and insurance cover. We see consolidations continuing as medical schemes are trying to protect the risk pool and amalgamations continue. And then, of course, we see a slow transition, as I said, probably to insurance. Ironically, if you look at the irony upon irony, the NHI Act says that the letter of the NHI Act suggests there isn't a space for medical schemes in the future. And perhaps then the space in the future will be, as I said, insurance. But regardless of that, there's so much uncertainty and so much litigation and so much dispute, so many potential future scenarios that we shouldn't be too quick to commit to a future scenario because, all of these court cases must play out and the political situation in the country must also play out. So I'm going to stop there, just noting that, healthcare is always political. And if you want to predict what healthcare will do, you're going to have to predict what will happen in the next elections. And good luck doing that. So I think we have about 20 minutes or so. Let me give the microphone back to Anthea. And just reminding, if someone wants to be unmuted or if you want to show your face, you can do that. Otherwise, I can just respond. And if Barry or Anthea also wants to chip in, you're more than welcome. I can just respond to the questions, perhaps one by one. I see we have a few in the Q&A functionality already. Thanks, Anthea.
Great. Thanks, Christoff. You deserve that sip of coffee. That was a really great overview, packed with a lot of thought-provoking insights on many aspects of our industry. And I think it just points to the complexities that we deal with on a daily basis. So we have a number of questions that have been coming through, both in the Q&A and in the chat. I see David, he has posted a number of questions, so thanks for that, David. A couple that Barry has already replied to or responded to, but maybe just to kick things off, Christoff, we have questions here from David. Firstly, Momentum's 2026 increase is larger than 2025, being an outlier amongst the ones that you showed there. Can you share any thoughts on why you think that is? And then I think David also had a question around how detrimental are low-cost insurance products for medical scheme sustainability. I think, potentially those two questions could be taken together. Thanks.
Let me start with the Momentum increase. I can't speak to the specifics of Momentum. I can just point out that Momentum did not go with as high an increase last year as many other medical schemes did. And that might be a contributing factor to why this year was a little bit higher. In the long run, you will often see, and I'm not speaking of Momentum, I think any medical scheme, and this is my aeroplane analogy, if a medical scheme does go with an extraordinarily low increase in any particular year, you will probably should not be surprised to see a higher increase in a future year after that. And, the groundswell of inflation is affecting all schemes equally. Some schemes have better and more efficient managed care and reimbursement and negotiation arrangements. So certainly there are some differences. But in the bigger scheme of things, pun intended, I think medical schemes, if you go with a very low increase one year, you might need to just compensate for that in the next year, which is why most medical schemes had a high increase last year. So I can't comment on Momentum. It might also have been a deliberate strategy of theirs to not correct the pricing last year, but to do it over a longer period of time. And, I think one would have to ask them what that would be. Anthea, you were just going to have to remind me the second part of the question.
Yes, sure. How detrimental are low-cost insurance products for medical scheme sustainability?
Yeah, it is a problem. I don't think we should, I have nothing against the existence of those products, and I think they're solving a very, very important problem. So rather than saying that insurers are detrimental, I would rather say, medical schemes, and I think this is the position of the Board of Health Funders and the Health Funders Association as well. They're not asking for insurance to be deleted. They're asking for medical schemes to be permitted to offer similar products. And I think that's really what the debate is all about. If medical schemes could, and it's really about being exempted for prescribed minimum benefits. The comprehensive package that lower income South Africans say we can't afford it, we don't want it. And that's a difficult debate because, on one level, you want to give everyone everything. That's also what NHI is intending to give, but our economy just can't do that at the moment. And I think the existence of insurance products is threatening the sustainability of medical schemes for the reasons that I explained. But I think the solution is not necessarily to delete insurance. It's to allow schemes to offer similar products and allow schemes to compete. And that was the intention when these primary healthcare insurance exemptions were originally granted to those insurers. In all of those applications, the intention was that ultimately those policies would be transferred to a medical scheme. And I think we've heard a number of open medical schemes and their administrators recently over the past few years say their preference would be for this business to be transferred into a medical scheme. And I think then to David's question, the sustainability of schemes would also be, would be less threatened. Maybe just while I see, it's great to have people like David on the call. You make me read so much. But the first question I have, or maybe it's David's last question, I'm not sure if I should read from the top to the bottom, but I saw David's question about Section 33. Let me just go to that quickly. Yes, David is correct. Section 33 says that only once NHI is fully implemented will this kind of restriction that medical schemes can't cover what NHI covers will come into play. So that's what the Act says. It's not a minority view. It's literally the words in the Act. But it says once it is fully implemented as determined by the Minister of Health. So we don't know what that means. When the minister says it's implemented, then it is implemented. Now, when will the minister say this? It could take a long time, and we've recently seen in, I think, some of the responding affidavits that the Department of Health says, no, but people are, medical schemes are still needed for the next 20 years, or, those kind of statements. Sometimes it's 10, sometimes it's 14, sometimes it's 20, and, suggesting that NHI won't be fully implemented. But we're not sure if you could take that view. And we're also not sure if the Medical Schemes Council will start prohibiting schemes from offering certain pieces of cover. Because remember, this is the NHI Act. But even before the NHI is fully implemented, we could see the Council of Medical Schemes saying to schemes, let me stick to my gynae example, say to schemes, well, NHI has now started covering gynaes, so as the Medical Schemes Council under the Medical Schemes Act, we're going to prohibit schemes from covering gynae benefits as an example. Just an interesting one for David. I understand from the litigants, the people who taking NHI to court, BHF, HFA, etc., that the Minister of Health has recently offered to postpone the implementation of Section 33 until all of the court cases are resolved, on the condition that all of the court cases be combined into a single case. Now, that seems to be a very hollow gesture to postpone something that would only be implemented once it is fully implemented anyway. So, they're taking that postponement kind of offer with a pinch of salt. Anthea, where do you want to go next?
Well, while we're here in the Q&A chat, and we'll move on to the general chat soon, Liesel has posted a question. I have a feeling what you might do with this one. In your opinion, what is the magic formula? Should medical aid be a condition of employment or not? And should you try to have a split risk in place or not?
Yeah, Liesel, so, get the prize for asking the difficult questions. Congratulations, you win. For the most difficult question or most important question, there is no easy answer to that question. There's a compromise here between freedom of choice and sustainability/affordability. I think, the trend at the moment is definitely towards freedom of choice. Everyone wants more choice. And for the reasons I've explained, that might result in some of the menu items on your choices to becoming more expensive. It might also result in older people ending up in a position where they must actually pay more for cover, and younger people can pay less for cover. So I can't wave a magic wand. I would say to you, if you have a restricted medical scheme, and if you have an employer with a fairly young and healthy profile, then without a doubt, you should try to retain that restricted scheme, and you should try to maintain a condition of employment. Because if you're younger than the average scheme out there, it just means that you will be able, within your ring-fenced restricted scheme risk pool, you'll be able to offer benefits at a lower cost than what open schemes can. Of course, even in environments, and I see many restricted schemes and some that offer exceptional value for money that are super young, still in those environments, there are pressure to say we want more choice and we want freedom of choice. And ultimately, I think it boils down to an ExCo decision. I can't just give you a text box answer to a very complex decision, and it differs based on the culture of the organization. It differs based on how paternalistic the employer is, and it differs based on the profile of the organization.
I think if I may just come in there, as a consultant to employer groups who largely participate in open medical schemes, if I look at the question, should medical aid be a condition of employment, and should you try to have a split risk in place or not? My view is that yes, it should be a condition of employment. I think with having healthcare cover as a condition of employment places health benefits on the same level of importance as your retirement funding and your group risk cover. It's ensuring a level of well-being for your employees. And having a split risk structure in place certainly can assist and optimize issues of accessibility and affordability. So in principle, I would support that approach, and I think it also has a general impact on the state of employee wellness and the knock-on effects in terms of absenteeism and productivity as well. So thanks for those questions. I think those are really great questions. Just moving on to the chat, I see we did have a couple there as well.
There's one I want to take quickly, if I can. I think
sure.
Lindy left us, but I'm going to respond to her question anyway, because it's really important. Yeah, so we're looking in the chat now. I think some people posted questions in the chat and others posted in the Q&A. But in the chat, you'll see, I'm not going to read Lindy's question. I'm assuming, I see Lindy left, but I'm assuming Lindy is speaking from a provider perspective. What I mean with a provider is like if you're a physio or a GP or a dietitian or a specialist. And Lindy is talking about how low the increases are. I called them 4% roughly in my very crude slide that I showed today. And I think she's right there. She's asking, is it fair for funders to reduce benefits by increasing it? And it's not fair. It's absolutely not fair for medical schemes to increase what they pay to doctors by less than inflation if the cost of running those practices are more than inflation. But the reason this is happening is because medical schemes find themselves in this very regrettable structure, that they need to find a way of keeping things affordable somewhere. And if you have young and healthy people exiting the system, that puts immense cost pressure on medical schemes. And I think the HR representatives and employers on the call will appreciate that the cost, a 6, 7, 8, 9, 10% increase for medical scheme is not pleasant to do with. So what ends up is that medical schemes have to put more pressure on providers and suppliers and everyone else in the system. And the fix to this is not just to pay more. The fix to this would have been to fix a regulatory environment which is suboptimal.
Thanks. Earlier on, we saw that there was a hand raised by Belinda Water. So Belinda, if you would like to post your question in the Q&A, you're most welcome.
I think Belinda asked to be unmuted. Yeah, that would be nice to hear an actual voice.
An actual voice.
And if Belinda doesn't have a bad hair day, then perhaps we could even see a camera, but I'm not going to put pressure. Let me just check with Suleiman and our support crew. Can you help unmute? So just give Belinda permission to unmute, please.
Good morning, everyone.
Morning, Belinda.
The question I have has already been answered. It was more around, should the medical aid be a condition of employment?
Right.
Because within our business, we have a lot of youngsters who feel that it's actually so unfair for them to be forced to join a medical aid when they are healthy and don't have any chronic conditions. So I think you've actually addressed that very well.
Thanks, Belinda. I just want to say, Belinda, you are not alone. I think every employer with a condition of employment, that's what we see, is the youngsters are angry. And I get it. I understand it. But that's a tension that I think every ultimately, it's in everyone's benefit if you can maintain like a restricted scheme that's healthy, and you might have one. And one of the interesting things to watch for when you deal with young and healthy people is often the example of neonatal cases of premature babies. It's just such an excellent example of where a very young married couple might think they are invincible. Nothing can happen to us. We're young, we're healthy. And then, you give birth to a premature baby. And now I've recently seen one of those cases that cost more than 10 million rands, just paid in full by the medical scheme. But that's a good example of sometimes what you think you need is not what you really need. And I think Belinda is just also reflecting those tensions are very real. They're playing out in every employer, every organization. I think we're reaching the end, but if someone wants to be unmuted, just raise a hand or shout very loud in the chat if you want to maybe ask another question.
Well, Belinda broke the ice for us, so please, we're happy to take any unmuted questions.
I said too much, Anthea. It doesn't look like there's any hands coming.
No.
But we made good time. But is it 2 minutes?
I think that's brilliant. We'll be able to close off literally on the dot of 10:30. So if there aren't any other questions, I would really like to thank you, Christoff, and thanks everyone else for your excellent questions, your comments, your engagement. It's clear that our private healthcare landscape is rapidly evolving and it's becoming increasingly complex. So understanding these shifts from an employer perspective is really important because you need to look at balancing cost, access, and employee well-being. And we just hope that today's session has given you some valuable insights and raised some important questions that you can reflect on as you plan for the year ahead. If you didn't get your question answered, please feel free to reach out to us on email because we'd love to continue the conversation with you. And we will share the slides with all registered participants, just as a reminder. But thanks again for being part of this discussion. And we look forward to,
Anthea, I'm going to interrupt you quickly. I think I went back to the Q&A. I see Liesel posted another question.
Okay.
Average age of most medical schemes currently around 34 years. You'll find that in the Council's Medical Scheme report. It's approaching 35 years, and that's per beneficiary, not per member. So don't look only at your employees. If you look at your employees and their dependents, and if they're younger than 34 years, then, that's a strong indication that you might actually be better off if you had your own restricted medical scheme. But maybe that's just to answer that question. The Council for Medical Schemes report provide that information every year. And I see there's a comment from Len. Thanks for the comments. I'll just leave the comment there for anyone else who wants to read it. Sorry for the interruption, Anthea.
No problem. Right. Well, thanks again, everyone. And we look forward to seeing you in our next webinar early in 2026.